When most people think about the healthcare system, they focus on doctors, the treatments doctors recommend, the prescriptions they write, the medical advice they give patients. But there is an earlier step in that process that receives much less attention. Before doctors ever begin practicing medicine, someone needs to decide how they're being trained. What will they study? What will they practice? And what they are taught to prioritize in patient care. Those decisions are made long before a physician ever walks into a clinic, and they happen inside of medical schools. Hello everyone, I'm Dr. V. Welcome back to my channel, and I am talking to you about who decides what medical professionals are being trained. And this sparked a discussion based on an article I saw about RFK Jr. He's talking about beefing up the knowledge inside of medical schools, and I was like, well, what's really behind that? Not just particularly of what he's doing, but overall about how our professionals are being trained and how it relates to how academic consequences or academic decisions leads to real world consequences. So let's talk about one story in particular. Recently, more than 50 medical schools in the United States committed to expanding their nutrition education requirements. Sounds like a good thing. Beginning next fall, at the time of this video, those programs will require medical students to complete at least 40 hours of nutrition training. Now, that might sound like a small adjustment, but historically, nutrition has occupied a surprisingly small place in medical education. Across nearly 200 medical schools in the United States, nutrition training averaged just about 1 hour per year. And I guess that depends on certain medical schools, whether you're there for 4 years, 7 years, but either way, that's still a smaller number compared to the 40 hours that are now talking about being required. So increasing the requirement to 40 hours represents a meaningful shift in how future physicians are trained. And that shift didn't just happen randomly. It emerged through a combination of government initiatives, institutional decisions, and broader concerns about chronic disease. You'll start noticing a pattern as we talk about these articles because there's more than likely an incentive structure. So in this case, public health officials have increasingly pointed to diet-related illness as a major driver of health costs. Conditions like heart disease, diabetes, and obesity place enormous pressure on healthcare systems. Some policymakers and medical leaders have argued that physicians should receive more training in nutrition and lifestyle medicine. Now, I'm a doctor, but I'm not that kind of doctor, so I found this interesting. So in response, federal health officials encourage medical schools to strengthen nutrition education in their programs. Officials emphasize that participation is voluntary, but most universities operate with a complex system of initiatives. So notice, we're not mandating that you do this, but if you do, there'll be some nice little things attached to it. And if you didn't know, medical schools depend on federal funding streams. They need research grants, public health partnerships, and accreditation structures. And when government agencies signal that a particular issue is becoming a priority, institutions often adjust their behavior accordingly, even when no formal mandate exists. So what's the hidden pattern behind this? This moment reveals something deeper about universities that many people rarely consider. Universities don't just transmit knowledge, they shape professional worldviews. And I know there's like a lot of discussion about, well, are universities or colleges even relevant at this point? But at a certain level, especially in your higher professional areas, it's still very relevant to this day. So the medical school curriculum determines how future doctors think about illness, what they prioritize when they diagnose patients, what type of interventions they view as most important. If nutrition becomes a larger part of medical training, that may gradually shift how physicians approach treatment. Some doctors may place greater emphasis on lifestyle interventions. Others may integrate nutrition guidance more directly into patient care. And these shifts happen slowly, but over time, they shape the practice of medicine itself. Now, what are the downstream consequences? Because there's always a consequence. And that's where the ripple effect appears, because medical education doesn't just stay inside of universities. The training physicians receive eventually influences clinical practices, hospital systems, public health recommendations, insurance structures, and even national healthcare spending. In other words, the curriculum decisions made inside medical schools today can influence how healthcare operates years from now. And honestly, I'm sure you can trace back some of the policies we're experiencing now to what was being taught in medical schools prior, especially the most prestigious and popular ones. This is why debates about curriculum become so intense. They are not just arguments about classroom content, and so many people think that, but they are arguments about the future direction of an entire profession. So I want you to think about this as we close. Stories like this reminds us that many of the systems shaping our daily lives begin in places we rarely examine closely. Universities play a quiet but powerful role in shaping professions. They train doctors, engineers, lawyers, educators, and business leaders. And the ideas embedded in those training systems eventually ripple out into society. So when medical schools adjust their curriculum even slightly, it can signal something much larger, because what starts in universities rarely stays there. And the way professionals are trained today often determines how industries evolve tomorrow. Let me know your thoughts and comments down below, and I will see you in the next one. Bye for now.